Assalamu alaikum. Today, the topic of my lecture is restrictive cardiomyopathy, which is the third and last cardiomyopathy that I'll discuss. What is restrictive cardiomyopathy? It is a disease in which ventricular walls become stiff and non compliant due to infiltration, leading to impaired ventricular filling during diastole, while systolic function is initially preserved. As there's fibrosis of the ventricles, hence the ventricles they fail to relax during diastole, so we also call it as diastolic failure. Now let's discuss the etiology. First is primary cause, which includes idiopathic restrictive cardiomyopathy or familial. Then is the infiltrative cause that includes amyloidosis, sarcoidosis, hemochromatosis. Then is storage diseases, yes, storage causes such as Gaucher's disease, Fabry's disease, Hurler's disease, or glycogen storage disease. Then is the autoimmune causes, which include scleroderma, polymyositis, dermatomyositis. And then are the endomyocardial causes, including endomyocardial fibrosis, metastatic cancer, carcinoid, and radiations. Now coming to the pathophysiology, it have following 6 points. The first is myocardial infiltration of fibrosis, therefore the ventricular walls become stiff. The second point is reduced ventricular compliance, hence, the ventricles cannot relax properly during diastole. Then comes the impaired ventricular filling, so the filling occurs only at high pressures. Then the fourth point is increased ventricular filling pressures. The pressures then back up into atria and venous circulation. Fifth point in pathophysiology is biatrial enlargement. As the name suggests, both atria they dilate due to chronic pressure overload. And the last point being preserved systolic function initially. So the ejection fraction it remains normal until the advancement of disease. Now coming to the clinical features, first I'll discuss symptoms, then signs. The symptoms include progressive dyspnea, fatigue, exercise tolerance, orthopnea, paroxysmal nocturnal dyspnea, peripheral edema, which is greater than pulmonary edema, abdominal swelling, which is known as ascites, thromboembolic events. Why? Because as there's fibrosis of the ventricle, so it triggers the clot formation. And lastly, poorly tolerated tachyarrhythmias. The signs of restrictive cardiomyopathy are hepatomegaly, ascites. The third and fourth heart sounds are audible. Friedrich's sign. What is Friedrich's sign? It is elevated JVP with diastolic collapse. And last is Kussmaul's sign. What is Kussmaul's sign? It is the elevation of JVP on inspiration. Now, let's come to the diagnosis of restrictive cardiomyopathy. The first investigation is chest X-ray. What are the findings in chest X-ray? Normal ventricular chamber size. Then we see biatrial enlargement. And lastly, we see pulmonary congestion. The second investigation is ECG. What are the findings in ECG? They are low voltage QRS complex, then conduction abnormalities, and lastly, arrhythmias. The third investigation is echocardiography, which is the investigation of choice. What are the findings in echocardiography? We see normal ventricular size, biatrial enlargement, symmetric wall thickness, preserved ejection fraction initially, but in later stages, there may be some disruption found in ejection fraction. Restrictive filling pattern and diastolic dysfunction. The next imaging is cardiac MRI, and what it detects is it detects myocardial infiltration and fibrosis and is particularly useful in cases of amyloidosis and sarcoidosis. Then comes cardiac catheterization, and an important sign of restrictive cardiomyopathy seen in cardiac catheterization is square root wave sign. The next investigation is endomyocardial biopsy, which is the gold standard. And the last test that is done is blood tests, and the blood tests include BNP, which is beta natriuretic peptide or NT-proBNP, iron studies in case of hemochromatosis, serum and urine protein electrophoresis in case of amyloidosis, and eosinophil count in Loeffler's syndrome. Now, coming to the management of restrictive cardiomyopathy. We have to treat the underlying cause. For example, if the cause is hemochromatosis, we have to do phlebotomy or iron chelation. If the cause is sarcoidosis, we have to give corticosteroids. If the cause is Fabry disease, we have to do enzyme replacement therapy. If the cause is heart failure, it should be treated with diuretics, salt restriction, and if we have afibrillation, we have to do anticoagulation. And last point in management is transplantation. Now, the complications of restrictive cardiomyopathy are heart failure with preserved ejection fraction, atrial fibrillation, thromboembolism, pulmonary hypertension, and sudden cardiac death. But the sudden cardiac death is less common than in hypertrophic cardiac myopathy. Thank you so much. This was all for the topic of restrictive cardiomyopathy. For more topics,